Good afternoon, and welcome to the AbbVie Symposium for Interest 2021. The topic for today is novel approaches to improve retention of HIV patients in care and treatment. I'll be chairing this session, and I'm Sipho Dlamini from the University of Cape Town, South Africa, and I'm an infectious disease specialist. So I'd like to really thank AbbVie for sponsoring this session. And just to remind you that some of the disclosures and disclaimers here, both by the sponsor and for the speakers. Just some housekeeping rules. Just make sure that your mic is muted, and just remember that there is an question and answer session at the end of both presentations. Please pose your questions in the chat box, and we will address those. So the agenda for today is we're going to have two speakers. The first speaker is Dr. Sikazwe, who I will introduce shortly. The second is Dr. Nell. And just to remind you that the session is looking at novel approaches to improve retention of care of HIV patients in care and treatment. I think this will be a very good session, and please don't forget to pose your questions in the chat box. So the first presenter is Dr. Sikazwe, who is from Zambia. She's an infectious disease specialist trained in the US, and currently is a Chief Executive Officer for the Center of Infectious Diseases and Research in Zambia. She's been involved in a number of projects in Zambia, both at the national level, and currently is also involved in the teaching of master students at the University of Zambia. She has had a number of grants and currently is involved as a principal investigator of a large HIV prevention and care and treatment grant, which is supported by PEPFAR and CDC. She's had a number of certainly grants that include treatment pathways in Zambia, and I'd like to welcome Dr. Sikazwe and looking forward to her talk.
I'm really happy to be part of this symposium that's being moderated by Professor Dlamini, looking at novel approaches to improve patient retention in care and treatment. My name is Izukanji Sikazwe with the Center for Infectious Disease Research in Zambia, also known as CIDES. So good morning, good afternoon, and good evening. So typically, we're really are familiar with the care and treatment cascade, moving more in a linear fashion from stage 1 to stage 4. So from diagnosis to long-term retention, and expecting our patients to seamlessly transition through diagnosis to viral suppression. But unfortunately, that's not how our patients behave. For the most part, they will move in this fashion, but sometimes they will drop in and out of care in this cyclical movement or revolving door where they engage and disengage based on various enablers or facilitators for their engagement in care. We do understand the implications of interruption to HIV treatment, mostly being advanced HIV disease with increased morbidity and death and increased risk of transmission to others. So it's critical for us to understand patient enablers and barriers for continued care to ensure that we can support our patients for long-term success. So looking at patient preferences for HIV services and long-term engagement really centers around a sweet spot, which in my mind is an intersection of understanding patient preferences, being patient-centered in our approaches, and also understanding the health system resources for long-term engagement. The numerous initiatives for long-term care, some of which we'll talk about in the symposium, but it's critical for us to understand what strategies or interventions are most preferred by patients and what service delivery features are most valued by patients. And then understanding the who, where, when, and the how of service delivery and uptake by recipients of care. One way of doing this is using discrete choice experiments. These have been traditionally been used in industry outside the healthcare system, but for over a decade now, they're becoming more and more popular to understand what characteristics or set of attributes are most desired by our patients. This helps us in terms of tailoring our approaches to be more in line with patient expectations, as well as what the available resources we have. One quote that stands out to me from a synthetic review that I'm going to talk about is providers that know me as a person. So as a healthcare system, we have to think of our patients beyond just an ART ID number or a data point in our larger program, but really understanding them as a person. There's a paper that was published last year by Wilson and others, which was a synthetic review exploring relative preferences for HIV services using discrete choice experiments. So they evaluated services between January 2004 and January 2020. And this synthetic review included 8 studies and 11 discrete choice experiments. 6 of these were done in low and middle income countries and 2 of these from high income countries. The discrete choice experiments evaluated responses from adults living with HIV, including women, and more importantly for our discussion, amongst those that were lost to follow up. Here's a snapshot of some of the results that were highlighted in the paper. And overwhelmingly, or more importantly, is that provider attitude was ranked really highly. So when they compared provider attitude to other service attributes, such as care for services, waiting time, opening hours, the distance that patients had to travel, they saw that patients really valued good provider attitude really highly. Provider attitude on the left panel is shown in red, and that it's ranked highly compared to other attributes where provider attitude ranked lower, as shown in the blue. This is repeated throughout for ART refill as well as waiting times. So patients living with HIV did not want short refills, but importantly, they will rank the longer refills lower to get other service attributes, such as good provider attitude. Further, long waiting times of up to 6 hours were less important than other service features, as you can see in the right panel, and their provider attitude again outweighed wait times. So patients were willing to wait longer in order to be seen by a provider who had an attitude that was more in line with what patients were looking for. Our work here in Zambia, that was a qualitative study trying to understand reasons why patients disengaged from care, also brought this sharply to us. They care rudely. So a quote by one of the patients was that when you go to the clinic and ask questions, they will shout at you, but they're not supposed to shout at us. Instead, they're supposed to encourage that person. But just to say the truth, one of the reasons why I stopped care is because they shout at us very much. They are rude. So as providers or the healthcare system, we have to really be cognizant and appreciate what our patients are telling us and some of the reasons why they disengage from care. Looking at the interventions that are available for uninterrupted care broadly, and these are the ones I'm going to touch on decentralized models of care, patient tracing activities, as well as patient-centered care. The WHO in its 2021 recommendations did recommend that ART should be given to patients for longer durations, at least every 6 months if feasible. And decentralized service delivery models, or DSD models, have really taken this up. But DSD models have to align with both resources available in the healthcare system as well as patient preferences. They They have to understand the barriers and exploit the facilitators for continued patient engagement. DSD models also have different attributes. They can be facility-based versus community-based. They can be targeted at an individual versus a group. And then also they can be given by a lay provider versus a professional healthcare provider. So the context is really key here. When you look at longer ART dispensation from a study done in Kailishi, South Africa, that looked at ART adherence clubs, and they compared a standard of care, which was 2-month refill for ART in these clubs versus 6 months refill. They were able to show that at 24 months, retention was similar between those that received 2 months of ART compared to 6 months of ART refill. And importantly, I think for us, looking at real outcomes, is that viral load suppression was similar in both arms. Closer to home for me here in Zambia, just last year during the COVID-19 outbreak, they instituted longer refills for children living with HIV less than 15 years of age. So the minimum ART refill was moved up to 3 months for this age group during the period when COVID first broke out. And they compared ART retention as well as viral load outcomes in over 27,000 children. They saw that the viral load coverage was not affected by these longer refills. And more importantly, the viral load suppression rates actually improved when they compared outcomes to a prior period. Interestingly, and also important, is that the loss to follow-up rates reduced. They went down to 5% compared to 17.4% prior to the introduction of the longer refills. Coming to tracing and re-engagement in care, WHO recommends that interventions should be put in place to trace people who have disengaged from care and provide them with support for re-engaging. There have to be effective means of really ascertaining the true outcomes of our programs. We have to be able to determine true disengagement from forced loss, which may be due to silent transfers or loss. And we also have to identify patients at risk of recurrent disengagement. Like I said in my opening slide, where you have the revolving door and the cyclical nature of patients coming in and out of care. We also have to have effective means of bringing them back to care. The South African MSF program has a really nice welcome back service package that looks at trying to make clients that are being disengaged feel more at home when they come back. On the right, you can see in the solid green line there, that patients that were lost to follow-up and were selected for tracing had a much higher rate of return to the clinic, as well as a shorter duration of time from disengagement, compared to those that were in the red, that are represented by the red line, that were not selected for tracing activities. Another good practice that is available in the 2021 guidelines from WHO is health systems should invest in people-centered practices and communications. And this includes ongoing training, mentoring, and support, essentially to improve the relationship between patients and healthcare providers. We have taken this on in my program here in Zambia, looking at person-centered public health for HIV treatment. And our goal really is to improve patients and healthcare workers' experience within the healthcare system, with the ultimate purpose of improving the outcomes of patients accessing services. Our aim is to evaluate the feasibility, the cost, and cost effectiveness of implementing a patient-centered care package. This is being done as a step wedge design in 24 facilities, and we began in August 2019. The intervention is around training and mentorship on patient-centered care approaches, HIV care management, structured data review meetings, and incentives for facilities that improve their performance. Some of the measurements that we have in place are provider and patient surveys, trained expert clients, and routinely collected HIV indicators such as viral load suppression rates and retention. A quick snapshot of some of our results, and this looks at the overall patient experience through SMS surveys. You can see in the blue bars, which is representing yes, and the red bars representing no, and moving from the left of the panel to the right, that during the different waves of these surveys that have been undertaken by more than 2,000 clients in each wave, you see that our patients are happy with care. They're seeing less providers being rude, and they're having more providers that listen to them and are engaged, and are spending less and less time within the facility. So essentially, to end, I want to emphasize that context is key. You need to understand your population. You need to understand what the enablers and barriers to uninterrupted care are, remembering that our patients are human and have different pressing priorities that might keep them away from the healthcare service or propel them into the healthcare service. So you need to be able to understand that and work within it. I want to thank you for listening, and I'm happy to take questions. Thank you so much.
So the second speaker is Dr. Jeremy Nel. He's from South Africa, Johannesburg, an infectious disease specialist. He works at the Helen Joseph Hospital. He's had some training at Chapel Hill, North Carolina in 2017, looking at infections in transplant patients. Dr. Nel is involved in the treatment guidelines with the Clinician Society guideline, and he chairs that guideline committee. He's involved as an investigator for HIV and TB research in Johannesburg. And Dr. Nel will be talking to us about retention in care, same-day initiation, and COVID related aspects of retention in care. And we're looking forward to Dr. Nel's talk. Thank you.
Welcome and thanks. It's a great privilege to be able to speak to you virtually at this wonderful conference. So I'm going to talk a little bit about retention in care, specifically about same-day initiation and also what COVID has done to retention in care within the HIV pathways. It's important to understand where the problem lies. These are the 90-90-90 goals, which, as you know, now have been upgraded to 95-95-95 goals. But this is where South Africa was in 2020. And you can see that for the first 90, the so-called diagnosis, in other words, how many people are diagnosed with HIV, this target was exceeded. So 92% of people knew their status. Of those on treatment, another about 92% were virally suppressed. So both of those targets were met. But you can see this middle group here, which is where the big downfall occurred, which is after diagnosis to being on treatment. And this sort of pattern is recapitulated really throughout the world. I can show you the numbers, for example, from Eastern and Southern Africa, and they are roughly similar. Again, good numbers for the first and third, but the middle 90, keeping people on treatment and getting them on treatment in the first place, is where most countries struggle. And so this is really a key intervention that needs to be gotten right, because otherwise the amount of viral suppression we're going to see is not going to be at the target level that we want for our populations. So what drives that middle 90 in terms of why is it a struggle? And really there's two big reasons. One is that you may never start ARVs, and that's a reflection of after being diagnosed, there's often barriers between that and initiation of antiretroviral therapy. Increasingly few now that the CD4 count is really not a criterion to start antiretroviral therapy, but that still is an issue. And then the second reason is that people can drop out of treatment. So in other words, they may have been initiated, but then they default their therapy a bit later, or there's issues and there's barriers in terms of returning to care. And those are in somewhat separate problems, and they need to be tackled a little bit differently. This first issue, this never being started, in other words, where there's barriers between your diagnosis and initiation, is not a trivial thing. This was a study from some years back now from Sidney Rosen's group, where they looked at all the barriers in terms of getting people onto therapy. And you can see here from the test, from HIV testing to the point at which they got CD4 count, only about 59% of people in this cohort made it. And similarly, from having a CD4 count to eligibility, and in those days, remember that CD4 counts were a barrier to starting ARVs. You had to be under a certain threshold. But again, about just under half of them made it between CD4 and eligibility within care. And then from the time that they were eligible to start antiretroviral therapy to actually starting, it was, again, only about 2/3 of them made it. And so you can see that overall, as the authors concluded, fewer than 1/3 of the patients who tested positive for HIV were actually retained continuously in care by the time they started ARVs. In other words, there was a huge fall off in people between the diagnosis and starting therapy for the first time. And some of these barriers are structural and have fallen away, such as the CD4 count, where it's no longer a barrier, but some of them persist. And so one really nice way of thinking about this is could you fast track that first process? In other words, could you start ARVs more or less on the same day or as soon as possible thereafter that the HIV test is done? So this was a nice study by Nathan Ford and his co-authors, which looked at all the research in terms of randomized controlled trials and also observational trials to look at the benefits and the risks of rapid initiation of ARV therapy. And that's really starting on the same day or really as soon as possible thereafter, not 2-3 weeks later after initiation, after you've had counseling, say, in between. And what they showed is that the same day initiation offers specific benefits from these randomized controlled trials. And this is just across 4 randomized trials that they showed increased viral suppression rates at 1 year, a relative risk there of 1.17. So what that means is you had about 17% increased chances of viral suppression if you started ARVs on the same day. There was also greater retention in care, at least in these randomized controlled trials. Again, relatively small, 11% increase, but that's not trivial when you have across a whole population. When you roll these sort of interventions out, that can be a large number of people. And those are statistically significant. And then reduced mortality as well. There was a relative risk of 0.53, so in other words, suggesting that about a 47% decreased mortality, but this was not statistically significant. That confidence interval crossed 1, so we're less sure of that. But again, certainly a trend in the right direction, as there was with reduced loss to follow-up as well with same-day initiation. Similarly, crossed that line, so it wasn't statistically significant, but again, they're trending in the right direction. And these were assessed when they looked at the randomized trials as being of high to moderate quality evidence. So this does suggest, again, there could be some real benefits to same-day initiation and really removing as many of the barriers as possible between starting, getting a diagnosis and actually starting antiretroviral therapy. But that's not the only, there's certainly challenges with that too. One of the big challenges, and we're going to come in a couple of slides to how to address some of these, was that you had to exclude certain key opportunistic infections, such as cryptococcal meningitis and tuberculosis. And that can be challenging if you want to start someone on therapy the same day, because you just have less opportunity to exclude these. People started on tenofovir typically need creatinine. So the question there was, what do you do about creatinine? Do you check it and then call them back if it's a problem, or do you wait for a result, which may delay you? Now, some of the patients described insufficient time to process the information. And then, of course, there's a limited time to disclose the HIV status. So the patients may not have the opportunity to tell their families, for example, or their loved ones, which could affect stigma and partner disclosure, and even sometimes, sadly, partner violence. And then there was also limited time for the providers, the doctors and the nurses, to complete all the steps. So sometimes the doctors and the nurses complain. So this wasn't devoid of challenges, but it did seem, at least from these randomized trials, as if there was some substantial benefit. Then there's other studies, though, which unfortunately in the real world suggest that this may not be quite as simple. Now, I'll just give you one from Kirschberger et al., which is really a recent paper, was just published a couple of months ago, which looked at the same day initiation, and this was in South Africa, and showed that the relative risk there in terms of negative effects, or this is really mostly increased loss to follow-up, was 1.48. In other words, suggesting that you had more loss to follow-up if you started people on therapy on the same day. Other studies have shown similar sort of things, although they're often not randomized in a real-world setting, that there may be more challenges than were uncovered from randomized trials. This is not entirely unexpected, because randomized trials are, while they're the gold standard in terms of evidence, they're also often not translatable directly to the real-world setting, where there's far less resources and often less time than in a clinical trial setting. So what could you do, though, if you're interested in doing it? I'm still a fan of starting people as soon as possible. In terms of ARVs, we've certainly seen it in our clinic, and we try and do that as much as possible. For Cryptococcus, we're lucky because you can do a serum CRAG, the cryptococcal antigen screening, and you can do that on a blood sample, the same sample you take for, say, a CD4 count, and you could do that immediately. That really, you can get a result in a few minutes. Tuberculosis, you can try and exclude from a symptom screen, and there are limitations to the symptom screen. It's not a perfect screening test, but that is one way of at least making sure that if, for example, you test positive for symptoms, so you have, say, a chronic cough or weight loss, that you investigate for TB rather than just starting immediately on ARVs, so that those patients get almost pulled out of the queue and sent into a different direction in terms of excluding TB. Some hospitals and some districts actually have universal gene expert testing on sputum as a way, again, of excluding TB, for example, in pregnant women, even if they don't have symptoms. So those are ways which you can try and exclude TB. In terms of creatinine checks, some, again, it depends on the resources. There are options in terms of point of care devices that can be done. And in those point of care devices, you get a result straight away. Alternatively, a more low-tech way, of course, is just to say, well, we'll check your creatinine, and if it's a problem, when we get the result, we'll call you back, even if you've had a few doses of tenofovir. That's not the end of the world. Increasing your clinic efficiency can always help as well. If there's not enough time, you can often find it can be done if the clinic is more efficient. And then having some sort of flexibility about it too. For example, about opening hours and things like that may help in terms of providing more time and space for the patients and for the healthcare workers themselves. But also things like, for example, if the patient says, I do want time to disclose and I don't feel ready to start, of course, this is not a time to force anyone. The patient has to be ready and they have to demonstrate they're ready. But the key here in terms of the conceptual change is not to let these barriers just fall into place automatically. There must be a reason why you're not starting the patient on ARVs as soon as possible. That really means the same day or as soon as possible thereafter. So that's really about HIV alone in terms of some of the issues about same-day initiation and the controversy around that. Like I said, in general, I'm a fan of it, but you do have to have a bit of nuance to it. Not everyone's going to respond the same way, and you do have to have some flexibility to it. But COVID has put its own challenges in terms of retaining people in care. And what I'm going to talk to you about is just really one really important paper which came out in 2020, if I'm not mistaken, but certainly looked at the effect of the lockdown due to COVID in South Africa on primary healthcare as relates to HIV. So South Africa, for those of you who don't know, had a pretty strict lockdown when COVID hit. This was so-called level 5, where people were confined to their residence unless they had a good reason to leave. And there was a curfew, for example, in place, which was quite strict in terms of after hours, and the reasons to leave were quite limited to your home. So you initially were only able to leave for things like essential work and like if you're a doctor or to get food, etc. But most other places closed. Even if you had a job, most of the businesses were closed. So the lockdown initially was a very stringent thing. And what it caused was profound disruptions inadvertently to primary care. And we can see that in this paper in terms of what happened to HIV. So let me talk you through this. Let's take this image on the top left here. This starts from 2018 on the bottom and goes through all the way to 2020. Where these dark gray colors are, that's lockdown level 5, 4, and 3 as the color changes. And then here we're looking at HIV tests per month. So what you could see before COVID hit and before the lockdown is that on average in South Africa, the number of HIV tests per month was gradually increasing, if you look at this line. And then what happened with the lockdown is this plummeted. And you can see here it went from somewhere around maybe 45,000 tests a month down to about 25,000 tests a month. So it was an enormous drop when the lockdown hit. And then it started to recover as the lockdown levels lessened. Now, I should make it clear that it's not purely the lockdown that drove this. The lockdown was a big reason. But for example, some people feared coming to hospital because of COVID. They're worried about catching COVID. Or sometimes public transport was less available, so they couldn't come even if they did want to. So it's a combination of factors. But you can see the effect really in terms of this line and how it just dropped off in terms of HIV tests per month. If you look down at the second one over here, this is ARV initiations per week. And you can see it was a roughly static number between 2018 and 2020, maybe a small decline, but roughly about the same. And then again, when COVID hit, this number dropped precipitously, and it took a long time to recover, and it hadn't returned to baseline when the study ended. And then if you look at ARV collections per week, again, this number was going up. With COVID, it actually declined, although just before COVID, it went up, suggesting maybe people were planning ahead for this and coming into their clinics early. And then in terms of missed visits per week as well, that shot up at the beginning of COVID. So really, this is just a snapshot. This is in South Africa, it's one country, it's primary healthcare clinics only, but it's 65 of them. And I think it's a good indication of what happened in many countries as COVID hit and the profound challenges that this causes in terms of HIV care. We know that there's lots of problems with having an unsuppressed viral load, and that may possibly include worse outcomes with COVID too. So it's doubly important to keep people suppressed. And if you look, for example, at this wonderful cohort from the Western Cape, which is a province in South Africa, where they looked at 3.5 million patients, of whom 22,000 were diagnosed with COVID. If you look over here, HIV positive appeared to be a risk factor for death. So anything on the right of this white line here, this red line, appears to be a risk factor for COVID, obviously predominantly age, but other factors too. But if you looked within that group, so it was about twice as likely to die if you had HIV in this cohort. If you looked within that group, HIV unsuppressed people and people with low CD4s really drove that, whereas people with good CD4s and suppressed viral loads appeared to be roughly the same risk of death as anyone without HIV. So it's again another big reason to keep people suppressed and to not let COVID disrupt HIV care. What can you do if you're in HIV care clinics? You can have, for example, non-pharmaceutical interventions. You make sure to try and prevent your patients from getting COVID, things like masks and social distancing, space out the clinics visits where possible, keep that viral load undetectable. And these clinics are going to need to adapt in the COVID epidemic to make sure that they are not causing people to default unnecessarily. Get people who are HIV vaccinated. Vaccines should be available to pretty much everyone, and HIV may be a slightly higher risk factor than others in terms of poor outcomes. So it's really important to have people vaccinated. And then remember that there's no reason to delay ARVs just for COVID. Obviously, if they're very sick, you can wait until they're feeling a bit better. But in general, there's no COVID iris. And so someone who's doing well, even if they recently had COVID or if they're asymptomatic, no reason to delay ARVs. At that point, I'm going to leave it, and I'm very happy to take questions at the end. And thank you very much for your time, and I hope that was helpful. Thanks.